Let's continue the second part of the lecture. In this part, we will cover the acute complication of diabetes mellitus as well as managing diabetic during fasting. Basically, the acute complication of uncontrolled sugar may cause hyperglycemia, which are DKA and HHS, as well as incident of hypoglycemia. The main difference between the DKA and HSS is the DKA mainly occur in type 1 diabetes mellitus and HSS on type 2 diabetes mellitus. Besides that, type 2 diabetic mellitus patients are able to secrete insulin, which will further break down the glucose to produce energy by glycolysis. But no insulin secretion in type 1 diabetes, or also known as absolute insulin deficiency. Even though there is a lot of glucose in the blood, the absolute insulin deficiency inhibits the glucose uptake by the adipose tissue and also muscle cells. Thus, these two cells are starved for energy. These events may cause patient to losing his weight predominantly. Glycerol and amino acids will enter the liver and further converted as pyruvate and produce lots of energy through the Krebs cycle. This will cause increased gluconeogenesis and glycogenolysis, which lead to hyperglycemia. These events can be seen in the plasma blood glucose, which more than 11 millimole per liter for DKA and more than 30 millimole per liter for HSS. High level of glucose will is excreted out through the urine, also known as glucosuria. Glucose is osmotically active, and waters will tend to follow the glucose, resulting increase in urinations, which known as polyuria. High loss of water lead to dehydration or thirsty, also known as polydipsia. This event will lead to hyperosmolarity, which also known as HHS. The lipolysis in the adipose tissue also produce the free fatty acids. Okay, please take note, these events only occur in DKA patients. The lipolysis in the adipose tissue will produce the free fatty acids, which will convert it to acetyl-CoA and further produce the energy and also the ketone bodies. Ketone bodies are important because it gives cell energy too, but it also increases the acidity of the blood. Normal venous pH was 7.3 to 7.5. That is why you're able to trace this clinical manifestation in DKA patients besides acetone smell breath, also known as fruity smell breath. To treat HSS and DKA, we need to treat the loss of volume by fluid therapy and potassium replacement therapy. Isotonic saline, which is 0.9% normal saline, will given together with 3 gram potassium chloride to be infused and monitor the electrolyte balance and glucose level. Within the first hour of this treatment, if the glucose level do not fall at least 3 millimole per liter after 1 hour, the patients will receive 0.05 unit per kilogram per hour insulin infusions. Hypoglycemia is defined by either one of these two conditions, which are low plasma glucose level less than 4.0 millimole per liter, beside development of autonomic or neuroglycopenic symptoms in patients treated with insulin or oral antidiabetic agents. Cognitive function can start deteriorate when blood glucose level drop by 3 millimole per liter, and this event does not fully recover for at least 45 minutes after the hypo episodes. The treatment of hypoglycemia can be self-treated. The patients will be educated to monitor the blood glucose level before the treatment. So we also encourage the patient to bring the glucose tablet at anywhere and anytime to prevent any hypoglycemia. If the blood glucose level in the range of 3.3 to 3.9 millimole per liter, we will suggest the patient, we will educate this patient to take 3 glucose tablets. If the blood glucose less than 2.5 millimole per liter, or the patient will be unconscious. And these conditions are severe. So need to bring this patient to the hospital to receive the dextrose 50% 25 ml IV infusions. So we need to monitor the blood glucose level every 50 minutes until the level more than 5.6 millimole per liter. Fasting in Ramadan is obligatory for all healthy adult Muslims. It is important to categorize patients who intend to fast based on risk stratification that we will discuss later. Those in high and very high risk categories should abstain from fasting. It is because fasting in certain individuals with diabetes may be associated with adverse outcomes, hence they are not obligated to fast. There are several potential risks associated with fasting in Ramadan, namely hypoglycemia, DKA, and dehydration. There is a clear instruction from the Quran on individuals who are exempted from fasting. This includes individuals with chronic disease such as diabetes mellitus in the Surah Al-Baqarah verse 184 to 185. Here are the evidence chart. Compare the incidence of hyper and hypoglycemia for both type 1 diabetes and type 2 diabetes. As you can see here, threefold up to fivefold hyperglycemia incidence increase for this diabetic patient that decide to fast, and fivefold up to 7.5 for severe hypoglycemic episode may happen to this diabetic patient that decided to fast. As a pharmacist, we need to classify this patient based on the risk level as stated here. We didn't encourage very high risk and high risk category of patients to fast. Patients who insist to fast should be advised them to monitor blood glucose level regularly and adjust their treatment regime. They should stop fasting if the blood glucose level less than 3.3 millimole per liter at any time during the fast or less than 3.9 millimole per liter in the first few hours of fasting or more than 16.7 millimole per liter. Diabetic patients who insist to fast need to adjust their time taken the medication. In principle, the non-fasting morning dose should be taken during iftar, and the non-fasting evening dose should be taken during sahur. The time taken of DPP4 inhibitors, extended release of metformin, SGLT2 inhibitors, and GLP-1RA should switch the timing to iftar. For sulfonylureas, the non-fasting day of glibenclamide and glycoside usually twice daily. So we will counsel the patients to continue the current dose on iftar and reduce or omit the sahur dose. Depends on the pre-iftar daytime blood glucose level during fasting. For insulin adjustment, not much differs with previous one. In principle, the non-fasting morning dose injection should be injected during iftar and the non-fasting evening dose should be injected during sahur. The sahur dose should be decreased to avoid any hypoglycemia during the daytime. The basal insulin, or also known as intermediate or long-acting insulin, the one daily dose, we should reduce the dose about 15 to 30% from the normal dose. And this dose should take at iftar. As example, if the patient receives 10 units of basal insulin during the normal non-fasting, he need to reduce the dose about 30%. And we will educate the patient to take 7 units of that particular insulin at iftar. For rapid or short-acting insulin dose, they need to take normal dose at iftar, omit the lunch dose, and reduce this whole dose by 25% to 50%. This dose titration should be performed every 3 days, and dose adjustment must made according to blood glucose level. The pre-iftar level resembles the basal insulin requirement. If the blood glucose on pre-iftar is too low, you need to reduce the basal insulin units of injection. The post 2-hour iftar and post 2 hours sahur indicate the adequate amount of insulin intake. If the level is too low, it indicates either too much of insulin intake, so you need to reduce the amount of insulin intake or less carbo intake. If the level is too high, you should increase the insulin dose. Let's do the case study. Mr. Bond, 68-year-old man, expressed his insist to fast in Ramadan despite your advice. Twice or 3 times per week of hypoglycemia, and he compliant to his medication. So this can be the subjective part of the SOAP. So on examination, his HbA1c level is 8.1% and the fasting blood sugar is 5.9 millimole per liter. We can say that he is quite good in controlling the blood sugar level. And this is the self-monitoring blood glucose level. Currently, he is on the metformin 1 gram BD and gliclazide 80 mg BD. So we can see that he is on the dual therapy of the medications. So for the assessment part, we can say that these patients control the blood sugar level because of the H1C and FBS within the range. And we can categorize this patient is very high risk patients due to multiple events on hypoglycemia. So for the plan, we will suggest the patient to continue the metformin 1 gram at sahur and iftar. For the gliclazide and 80 mg to take at iftar and omit the gliclazide at the sahur dose. Need to educate this patient to monitor the self-monitoring blood glucose, especially at pre and post sahur and iftar and during the daytime, and educate on risk of hypoglycemia, hyperglycemia, and dehydration. Let's move to another case study. 50-year-old man with underlying type 2 diabetes and hypertension expressed his insist to fast in Ramadan despite our advice. On examination, his BP is 130 to 80 and HbA1c about 7.2%. This is the medication that he is on currently. So for the assessment part, we can say that these patients are controlled in the blood sugar level because of the A1C achieve the target. Based on the risk stratification, this patient is high risk patient because he has the hypertension. For the plan, we suggest the patient to continue the metformin 1 gram at sahur and iftar. For the start 30 to 20 unit BD, which refer to 30 units in early morning and 20 units in the evening. We suggest to continue the 30 units of morning dose at iftar and reduce the sahur dose to 10 units, which is 50% of the 20 unit. And we need to educate the patient to monitor the self-monitoring blood glucose, especially at pre and post sahur and iftar, and educate on risk of hypoglycemia, hyperglycemia, and dehydration. That's all for today. Hopefully this slide or this lecture are beneficial for you guys in your future, especially in your clinical year. Salam Ramadan. Assalamualaikum warahmatullahi wabarakatuh.